goals of the Center for Healthcare Innovation are broader than Pitch Day itself, but everything about Pitch Day really embodies the major goals of our center. We aim largely to conceive, test, and implement ideas that will improve healthcare for patients, providers, and others in our community. And every one of the projects that you'll hear about in Pitch Day embodies that. But we also want to support clinicians and staff in helping to make Penn Medicine a place where change happens, and more generally, to make Penn Medicine a place that can be recognized for the kind of innovation that we can deliver, not just regionally, nationally, and internationally as well. So this program really serves as an intake mechanism for a lot of the transformative work that we do within the center, but it's situated within a series of other projects that follow a very similar pattern. We have done Pitch Day and the Accelerator program since 2013. Since that time, we have crowdsourced over 500 proposals from passionate staff members across our academic enterprise. We've launched 31 projects, and 150 health system staff have been engaged throughout, and you're going to meet some of those individuals in the most recent cohort today. I'm going to turn it over to Roy to give you some examples of what projects look like in their later stages and to discuss some other issues.
Hi, so while we're talking today about everyone who's in phase one, the goal is to get across to where the blue circles are, right? To become the way that Penn Medicine works. Nothing gets from left to right without a lot of help. So there's a chance for us to also stop and appreciate and applaud our partners. So for you to even get in the middle, let alone the right, you have worked with our IS partners, with our entity executives, with our CMIO team, with the department chairs, with the strategic decision support. Every single person here knows that it takes a village to get from the left to the right. So we thank everybody because we couldn't do any of this stuff nearly on our own. So what you're seeing, though, is that it's good news. We know now that we actually can transform healthcare and we can actually get people across that chasm. About 10 projects out of this one particular program, out of those 31, have made it so far. It's about 1/3. So our batting average is just behind Bryce Harper and Reese Hoskins. just behind, but ahead of the rest of the fellows. We really pride ourselves in being able to experiment very quickly at low cost. And the reason that you see some of these teams who have done 6, 7, 8, 9 pilots within a few months is that we have made investments in these kind of platforms. So Way to Health, actually by David and Kevin several years ago, is a way to stay connected. It's a way to manage and deliver on the other 5,000 hours, staying connected to patients once they leave the premises, once they leave our walls, and see the things we need to be able to act on. Agent is another platform that's homegrown and a wonderful platform that allows us to identify who within a population needs help. Who should we pay attention to and act on, and then coordinate the care where a care team can do what needs to get done to keep that patient safe or to get to a better outcome. But first, finding the people who need that help. So you'll hear these discussed across several of the projects today, and we want to pull them out ahead of time so you know what we're talking about. And with that, I just want to say thank you to the leadership of Penn, to Kevin, to Ralph, to Larry, for supporting innovation, for allowing teams to experiment, because it really does take a lot of work and a lot of effort and a lot of investment in the infrastructure to be able to do it. So thank you for allowing us to do this work.
Thank you so much for having me today. My name's Jess Galton. I'm a neonatology fellow here at HUP, and I'm so excited to tell you about healing at home. First, I want to talk about my story. This is my son, William, just moments after he was born here at HUP. Fortunately, he and I were healthy and didn't have any major medical complications. I was told that we had to stay in the hospital for 3 days after he was born to meet all of our discharge criteria, which was routine for vaginal deliveries. But working at HUP, I wondered why we couldn't leave earlier. I was familiar with the discharge process. Why couldn't we leave earlier? What I wanted more than anything was to get back to my daughter and husband and bond with my son in the comfort of our own home. So I wondered if other patients at HUP felt similarly. In fact, we found that 80% of low-risk women who had vaginal deliveries also wanted to go home earlier. That led us to the question, well, what's stopping us from sending them home earlier? To answer this question, let's walk through a typical hospital experience for these patients. The average length of stay is 50 hours, or 3 days. the baby's health screenings are typically done at 36 hours. When I stopped to think about this, I asked, well, why is this done this way? Why is it done at 36 hours? The answer I got was, that's just how it's done here. This is one of the hardest problems to solve in healthcare. But we know that doing the baby's health screenings as early as 24 hours is safe and the standard of care at other hospitals. And we know that mothers are ready to leave at this time. So they're just waiting around for their babies to be discharged. To put this into context and understand why this is important to the hospital, let's talk through what should happen ideally. A pregnant woman comes to the hospital in labor, gets evaluated at the perinatal evaluation center, is moved to labor and delivery where she gives birth to her baby. Shortly after delivery, they're moved to the postpartum unit where they stay until the time of discharge home. As you can imagine, discharge delays create a bottleneck and back up the entire flow, preventing women from going home. Not only does this decrease our capacity to deliver more babies, but this also leads to women giving birth to their babies in unsuitable places, such as hallways and triage areas. All of this leads to negative patient experience. But the story for mom and baby doesn't end in the hospital. When I got home, even with a supportive husband and coming from a medical background, I felt like I was falling off of a cliff. Like other women, I wasn't going to see my OB doctor until 6 weeks after discharge. During this time, I felt anxious and isolated. When mothers get home, they need more support. Many struggle with postpartum depression, with issues related to breastfeeding, with pain. And many, especially at HUP, don't have the social support to help them get through these issues. Imagine being a stressed out, tired, new mother trying to care for your baby, sometimes alone, and having to sift through a whole bunch of information on the internet, trying to search for an answer to your basic question because you don't want to wait for your doctor's office to call you back. Sometimes it takes hours or even days. Now, I want you to imagine a new health system. One that supports moms and babies based on their individual needs in an environment that they wanted. The Healing at Home program aims to redesign the postpartum experience by streamlining inpatient workflows to decrease length of stay, supporting moms and babies as they transition home, and once they're home, individualizing services to provide high-value care. This is the current system, where services in the hospital and home are disconnected. This is the new system that the Healing at Home program has created. First, we reduce the time in the hospital, and then we provided targeted care at home to keep patients there safely. Let's start by talking about the interventions that we tested in the hospital first. One of the reasons that length of stay projects traditionally fail is that there's so many provider teams involved, which creates fragmented communication systems and interdependencies in workflows. We initially presented the idea to move the baby's health screenings earlier and met resistance. Some clinicians were worried that patients would have comorbidities when they got home. Others were worried that they would feel pushed out of the hospital too soon. Ultimately, we were able to convince our stakeholders to move the health screenings back to 24 hours for all 50 vaginal deliveries during our pilot period. But we had to do a couple of things first to make them feel comfortable. Our team modified existing clinical protocols for all of the provider teams involved. That was not easy. For the nurses, for example, we used the cards that they already used, moved the timeframes earlier, and then made the cards green, not rocket science, so that they knew that their patient was on this new clinical pathway. Our innovation team spent a lot of time on the ground facilitating communication and coordination in order to improve efficiency. Ultimately, we were able to reduce length of stay by 40%. This was a 19-hour decrease, or one less hospital day. Not only were we able to reduce length of stay, we were also able to do it safely. None of our patients were readmitted or seen in the ED during the first month after discharge. Now, I want to move to the interventions that we tested in the home. We listened to our patients, and we knew that they wanted more easy access to medical advice, and we knew that they would have a ton of questions. So, using Way to Health, thank you, David, we created Penny, a personalized postpartum assistant, a text bot that provided rapid, clinician-approved answers to questions at the touch of a button. Our team answered over 2,000 texts from 92 patients in the span of 2 months. Once patients texted us once, they were hooked. They texted us, 96% texted us 2 or more times. Moms told us that they loved this program. One woman said, "I want to give you 100 stars, faster and more direct than looking online or calling my doctor." We also found that the #1 struggle that patients had once they got home was with breastfeeding. I can definitely relate to this. 40% of our patients needed additional lactation support. We were able to do this in a targeted, high-value way by first triaging their concerns by text, and then for those who needed it, we helped facilitate telemedicine or in-home visits. 100% of patients told us that this was critical for establishing breastfeeding. For our pilot patients, we also facilitated private nurses going into the home, evaluating mom and baby to ensure their safety. This was covered by their health insurance. Through our pilot, we were able to improve healthcare utilization by preventing unnecessary pediatrician and ED visits, catching medical problems earlier, and appropriately referring patients to their doctors when needed. Looking to the future, there are many benefits to Penn and our payer partners. We believe we can increase throughput and capacity and decrease unnecessary healthcare utilization. By expanding the Healing at Home program to all of the delivery hospitals across Penn, we believe we can decrease length of stay by 40% for over 3,000 patients a year. This is for vaginal deliveries alone. Imagine what we could do if we expanded to other patient populations. Increasing capacity would lead to a $1.5 million contribution margin for Penn. Now that we understand the problem better and believe that the Healing at Home program can have a positive impact, we want to further refine our interventions and test them at scale. Ultimately, we want to provide parents with the care and support that they need so that they can focus on those first precious moments bonding with their babies at home. Thank you so much.
Imagine that you're a school bus driver. You're supposed to pick up 10 students on your route. But when you get to school, you turn around and find that there are only 4 students on the bus. 6 of the students that you were responsible for are still waiting for you on street corners throughout the city. Now imagine that bus driver is our health system. And these students left behind are the over 6,000 patients at Penn Medicine who are at risk for hepatocellular carcinoma, also known as HCC or liver cancer. In order to catch this cancer at a treatable stage, patients with chronic liver disease should be screened every 6 months with an abdominal ultrasound. Research shows that the 5-year relative survival drops significantly after early stage diagnosis, down to only 2.4%. Frequent screenings are critical in being able to diagnose and treat this cancer. The problem is 60% of patients are diagnosed too late to be cured. I'd like to tell you a real story. Meet Sam, a patient at Penn Medicine who was one of those 60%. Sam had cirrhosis, among other medical concerns, and over the span of 3 years, she had been seeing her primary care physician, Dr. Swift, in preparation for a major surgery. But over those 3 years, she only made it to 2 appointments with her hepatologist, Dr. West. When we looked back at Sam's story, we discovered that she was occasionally reminded by her physicians to get her HCC screening done. But we also discovered missed appointments and opportunities to have had the screenings ordered. By the time Sam finally got an ultrasound done years later, she was diagnosed with late-stage HCC. Everyone was devastated. For primary care physicians in particular, keeping track of at-risk patients like Sam is like keeping track of a needle in a haystack. To highlight this, 560 is the actual number of patients cared for by one of our primary care physicians. Yet only one is eligible for HCC screening. As a physician, imagine having to remember a task that takes up only 0.002% of your workload. But for this one patient, it's everything. This isn't an isolated case, as the majority of Penn primary care physicians face this almost insurmountable task. There are many reasons as to why staying on time with screening is difficult. First, it's not easy to know who's eligible. There are more than 20 factors that could make a patient eligible for HCC screening. Not only is it hard to know who's eligible, but there are also competing medical concerns that a physician has to prioritize within a visit, so screening may fall to the wayside. Within the past year, PCPs and hepatologists only placed orders for 60% of their eligible patients, leaving the other 40% behind on their 6-month screening schedule. And lastly, there are competing needs on the patient side that make it difficult to follow through with screening, such as cost, inconvenience, and other more pressing medical needs. As we've seen, no one person is at fault for a patient falling through the cracks. This is a multi-layered problem that needs a multi-pronged solution. A suite of solutions, in fact, that eliminates the burden on physicians to know who's eligible for screening, makes it easy for physicians to do the right thing, and makes it easy for patients to follow through with screening. We call this suite of solutions Live Aware. I'm Tessa Cook, I'm a radiologist here at Penn Medicine, and I'm going to tell you about Live Aware, our HCC screening and navigation platform. First of all, how did we eliminate the burden on physicians to know who's eligible for screening? There's currently no registry built to identify these patients, so our team tried to identify them on our own by creating a dashboard. As we went through the various iterations, we discovered that properly identifying these patients is not as simple as plugging in one diagnosis code. It requires analysis of multiple pieces of information that live in different parts of the patient's record. This dashboard was used by our team to identify the right patients for our interventions and informed how we might build a registry in the future. Next, LiveAware sought to increase the overall number of orders placed by removing the burden of remembering to order the screening while addressing competing priorities during a visit, thereby making the right choice the easy choice. A LiveAware team member would do the heavy lifting of creating a pending order, which would then present itself within Epic and trigger the physician to sign. And because we made orders standing orders, the physicians don't have to worry about signing another order again for the next 6-month screening. With our dashboard, we looked at 11 physicians over 1 month and identified 23 of their patients who were eligible and due for screening. After pending orders for these patients, we learned that our dashboard isn't perfect. Physicians identified 6 patients who didn't need to be screened. Of those that were appropriate, 3 patients' orders were missed. This made us realize that we need to think about different ways of notifying physicians of patients' eligibility for screening. To date, 14 of the orders LiveAware has placed have been signed by physicians. That means 82% of orders that we pended were signed. 5 of those patients had screenings that would otherwise not have been ordered. These are our catches. Our intervention resulted in a 22% increase in screenings ordered from our baseline. Primary care physicians loved the system and the increase. This is an example of one of our catches, where the physician mentioned they likely wouldn't have placed the order had it not been for LiveAware. At the system level, LiveAware can catch over 2,000 patients at risk for HCC within Penn Medicine who might otherwise be missed. A big part of the friction to getting screenings completed is the fact that patients have to show up to their appointments to get screenings ordered. To remove this reliance on appointments, the LiveAware team had physicians preemptively sign orders and engaged patients through My Penn Medicine and phone calls. For those patients that did show up to appointments, LiveAware piloted bundling same-day screenings with the appointments. 3 patients who were offered same-day screenings completed them. And 1 patient indicated that they would have skipped their screening otherwise. We've made great progress in solving this problem and have a long road ahead of us. But what does it look like when we get this right? That's 1 more screening done, which potentially prevents another story like Sam's. LiveAware can benefit the other 6,000 Penn Medicine patients like her. By ensuring patients get screened every 6 months, we can reduce the number of late-stage diagnoses and improve outcomes. Besides patients, LiveAware benefits physicians, payers, and Penn Medicine. We know LiveAware offloads the cognitive burden of identifying eligible patients from physicians. We can benefit payers by reducing the expensive downstream care necessary to treat late-stage HCC. And we know that by reducing the number of late-stage diagnoses and increasing the number of early-stage diagnoses, the health system can benefit from larger contribution margins for the procedures done when we catch and treat early-stage HCC. LiveAware doesn't just help the 6,000 patients at risk for HCC. We can navigate other complicated screenings for diseases such as colorectal cancer and polyposis syndromes, aortic aneurysms, breast cancer in patients with first-degree relatives, lung cancer, and many more. The possibilities are endless. I would like to acknowledge the incredible team with whom I've had the privilege of working on this initiative, from radiology to hepatology to primary care, and in particular the talented team at the Penn Center for Healthcare Innovation. Thank you.
Good afternoon. I'm Julie Dees, Director of Behavioral Health at Penn Presbyterian, and I'm here to share with you the incredible work we've been doing to address the opioid crisis in Philadelphia. Let me introduce you to Nicole. She's a 35-year-old woman who's been struggling with heroin use on and off since she was 19. Because of this, she lost custody of her 2 young daughters, but she's determined to recover so she can get her kids back. But one day, she had a reoccurrence of use. She's found unresponsive on the trolley. EMS arrives, administers Narcan, and takes her to the Presby ED. When she's stable, she's discharged with information about the risk of heroin and given a phone number for a local rehab. Her aftercare instructions simply said, "Please stop abusing these multiple drugs. It will lead to your death." Laura's addiction is a medical condition, but the treatment she received failed to address it. Fighting addiction is an uphill battle, and yet Laura left the ED alone and without a plan. We must do better. Philadelphia has by far the highest opioid overdose death rate of any major city. We're Penn Medicine. Philadelphia's health problems are our health problems. There are about 2,100 yearly visits from patients with opioid use disorder, or OUD, in our 3 central EDs. That patients pass through without evidence-based treatment represents a catastrophic failure. We must do better. Treating substance use isn't easy. Historically, rehab and detox were the standard treatment, but success rate is 5 to 10% at best. But there is good news. Medications like buprenorphine and methadone are 60 to 80% effective. Buprenorphine, or bup for short, is unique in that regulations allow it to be prescribed and administered in the ED. We got more good news. We got these guys. Presby offers bedside counseling from certified recovery specialists, or CRSs, as well as outpatient substance use treatment. When we started this work, about 175 OUD patients visited the Presby ED each month. 10 of those were started on bup, and only 4 received a consult from a CRS. Why were these resources so underutilized? We identified some key barriers. First, patients must be identified. Many ED visits from OUD patients present for reasons that don't seem related to substance use. This makes them very difficult to identify. Additionally, many providers simply weren't aware of Penn's substance use services. And we were counting on the providers to call us which is both time-consuming and easy to forget. Second, patients must be offered evidence-based treatment. Not every OUD patient can or wants to start on bupe in the ED, but more importantly, there were only a handful of providers that were trained in using bupe. Third, patients must have access to continued treatment. Physicians were hesitant to start patients on bupe because they didn't know how or where patients would continue treatment post-discharge. Additionally, few doctors had their X waiver, which is the training required to write a script that would allow patients to remain on bupe until their next appointment. You can imagine this like a funnel with drop-offs at each barrier. We set out to address these drop-offs, beginning with identification. We started by manually reviewing the Presby ED board and notifying our recovery specialists when we found a patient likely to have OUD. Truth be told, we struggled to predict which patients needed their support, but we were successfully identifying more patients and the recovery specialists were able to take action. But this high-touch model wasn't scalable, so we developed an automated system to monitor the ED and automatically alert our team of likely OUD patients. Over time, and with many, many, many revisions, we got better at predicting which of these patients needed our support. This system helped us rapidly scale our intervention to HUP and PENC. We've gone from identifying only 6 patients per month to over 100. We've learned that patients with limited chart information can't be easily identified, so we wondered, would these otherwise unknown patients be willing to self-identify? So we tested this by creating these posters and putting them up around the Presby ED. We asked patients to call us if they felt like they would need to talk about this. And to our surprise, the very first week, someone called. And many calls have come in since then. And as an aside, the Surgeon General happened to post this very picture on his Twitter feed. I would encourage you to look at it. Not to brag. Building on this, we piloted a screening question in the ED. When asked if they'd used illicit drugs in the past 12 months, 1% of patients said yes to opioid use, but had no evidence of it in their chart. At scale, this question could identify over 1,400 patients each year that otherwise would have been missed, and that's just in the ED. Next, we focused on ensuring patients received evidence-based medication treatment in the ED. Dr. Perrone led a campaign using incentives to dramatically increase the percentage of X-waivered ED faculty. We used social norming strategies like public messages and pins to celebrate and encourage the use of bupe as a first-line treatment. And to account for the difficulties our patients face staying in touch, we turned to a low-tech but appropriate solution. We provided patients wristbands, like the ones at your seat, with our contact information so they could reach us when they needed support. Let's look at how far we've come. Bupe use is increasing. More importantly, a greater share of eligible patients are starting on bupe in the ED, more than triple from where we started. Our recovery specialists are increasingly involved in ED care. And look, we have already expanded to all 3 of our downtown hospitals. We're reducing ED visits. Patients consulted by a CRS in the emergency department were significantly less likely to come back to the ED within 30 days of discharge. And this slide makes me smile every time. When there were very few patients that presented to the ED that were ever asked about substance use, given any sort of treatment options, or certainly enrolled in any sort of treatment options. But now, when patients receive both a CRS consult and are started on bupe, 68% not only start treatment, but are engaged in treatment at 30 days. That is remarkable. At our current rate of bupe use, we will prevent an estimated 187 overdoses each year. This work is transformative. We're changing lives, we're saving lives, and we're just getting started. Think back to Laura. Before our work began, she left the ED feeling judged, without treatment, and without support. Imagine she overdoses again and ends up back in our ED. This time, the system we developed automatically identifies that Laura is there and automatically notifies Nicole, our CRS, that she's in the ED. Nicole can go and speak to Laura bedside. They discuss Laura's treatment goals and her options. She says she's determined to get her kids back, and she's ready to try Bupe. Her physician gets her started, Nicole schedules a follow-up appointment at a Penn clinic, and Laura's given a bridge script so she can continue taking her medication until that follow-up appointment. This time, Laura leaves the ED on the right path. She has a plan, she has evidence-based treatment, and she has a peer to support her along the way. That, in a nutshell, is CORE. We're ready to take this to the next step and expand CORE into the hospital, which we see as a natural extension of the work in the ED. In speaking with inpatient care teams, we believe a CORE-led addiction medicine consultation service will result in improved outcomes, shorter lengths of stay, and reduced readmissions. We will be piloting this service in Presby starting in May. This is our city. We're in crisis, but we've shown you a way forward. With your support, we can continue to build on this critical work. Thank you.
There are 160 people in this room. Imagine you are all patients hospitalized at Penn. Some of you came in with heart failure, some have pneumonia, and generally you're all very sick. If you have a blue MEND button in front of you, please raise your hand high. You are in psychiatric distress. Yeah, shouldn't be that many. You are in psychiatric distress. Your medical team has asked a psychiatrist to see you, but this will happen closer to discharge than admission. It's after you're sleep deprived and anxious. It's after you've been labeled as difficult. It may even be after you've been put in physical restraints. Yet you are the lucky 6%. Now, if you have a purple button, please join the blues in raising your hand. You have not seen a mental health provider, but we now know you should have. Look around. It's nearly half. Almost all of you rate your mental distress as a high priority and want it addressed during your stay. Now, if you have an orange button, please join. This should be everyone. You do not need to see a mental health provider, but you're part of this because your team is busy managing those other complex cases. In the end, everyone's care is affected, and you are all staying in the hospital for longer than necessary. Please lower your arms. That was a workout, I know. My name is Cecilia Livesey. I'm a psychiatrist at Penn, and I'm here today to introduce MEND. MEND stands for Mental Health, Engagement, Navigation, and Delivery. We set out to flip the mental health paradigm, from reactive to proactive engagement, from siloed to integrated care delivery, from sporadic to continuous navigation of complex needs. And we hope to take mental health from costly to sustainable. MEND refuses to accept mental health as a separate stigmatized practice, accessible by the few. It uses 21st century tools and the power of Penn to make psychiatry an integrated part of medicine and our city. But it isn't just our city or our state. Mental health is a national crisis. It is the #1 cause of disability. The majority who suffer go undiagnosed for an average of a decade and die 10 to 25 years younger. The economic toll is estimated at $500 billion a year, and the individual toll is immeasurable. During this event, 180 people will take their own lives. That's more than everyone in this room. We all want to help, and the system is broken, so let's mend it. We started this project knowing 3 things. First, mental health care at HUP is limited. Last year, there were 1,000 psychiatry consults. We've calculated that there should have been at least 10,000. Second, patients with mental health diagnoses were staying here 22% longer. That's an extra 30 hours. Third, patients weren't just being held here longer. They were literally being held here. HUP patients spent more than 500,000 hours in restraints last year. At any point in time, there were 60 individuals across the streets tied to their beds for their own safety and for the safety of those around them. We started on 2 general medicine floors, founders 12 and 14. While rounding with the medical teams, our initial insight was that this was a problem that struck at the heart of our providers. 98% felt that their ability to provide care was compromised by patients with mental health comorbidities. They wanted to help, but the system was broken, so we started to mend it together. Step 1, we moved from reactive to proactive engagement. We wanted to identify patients with mental health needs the instant they hit the floor. So our first innovation was a machine learning algorithm. We knew that chart reviews were too time intensive, and discrete data gave us more noise and signal. So we thought, wouldn't it be incredible if we could bring forward the words that providers already use to describe their patients? Surprisingly, we were able to do just that. We reviewed 300 patient charts, identified those with mental health needs, and trained an algorithm on the raw note text. Today, the algorithm is based on over 1,000 statistically significant buzzwords, some expected, like depressive and suicide, and others unexpected, like victims, noncompliance, and consequences. Step 2, move from siloed to integrated care delivery. Our hypothesis was that by embedding a full-time nurse practitioner, a full-time social worker, and a part-time psychiatrist, we could address patient and provider needs more comprehensively and at less cost. Each morning, the MEND team uses a dashboard, prioritized by MEND score and confirmed by rapid chart review, to triage patients to the most appropriate provider. While rounding with the medical teams, MEND provides guidance on medication management, interpersonal dynamics, and crisis de-escalation. For patients, MEND delivers evidence-based psychotherapies, motivates patients to engage with treatment, and helps them see and overcome their barriers to care. Now our results. First, we went from identifying 6% of patients to 49%. This may seem high, but it's consistent with the literature, and we're confident that we're capturing nearly everyone in need. And instead of identifying patients on day 5, we're seeing them on day 1. And we're doing this with greater than 85% accuracy. We now see all you purple buttons. Second, in the 4 months before we started our MEND pilot, the psychiatry consult service saw 78 patients. In the 4 months of MEND, we blew past our goal and saw 309 patients, a 300% increase. Leveraging PennChart's capabilities, as well as over 15,000 curator messages exchanged between MEND and medicine providers, we became one team. Everyone was performing at the top of their licensure, and we were fascinated to find that only 1 in 5 cases required our MEND psychiatrist. For patients, the results have been meaningful. We've reduced restraint use by 1/3, and there also have been fewer safety events, hours of one-to-one use, and patients leaving against medical advice. And importantly, there's been a culture change. Providers are more aware of their patients' mental health needs, have more time to focus on the primary medical problem, and call MEND life-changing. Fourth, we needed to know that the solution could be sustainable. We were cautiously optimistic that we had found an economic lever when we saw length of stay decrease by 1 day in the raw data. When we controlled for other floors and other confounding variables, we found a statistically significant reduction in length of stay that was attributable to MEND. And for our most vulnerable patients, our Medicaid patients, we saw an even greater reduction at 1.5 days. Even patients with no mental health needs left the hospital sooner. Providers were more supported, and they were able to deliver timely care to all you orange buttons. We call this our MEND halo effect. With the help of strategic decision support and accounting for the cost of a MEND team, we've estimated we could save the system $2 to $4 million on length of stay alone. And that's just on 2 floors. For Penn, this is a new era of innovation and impact in mental health. For payers, this is truly high-value care. For providers, this creates a culture of wellness. And for patients, this is transformative. But you may have noticed that we skipped number 3, our N. While we saw a small reduction in 30-day readmissions and emergency room visits over the course of our pilot, we knew that helping patients navigate barriers to outpatient care would be our most difficult task. So we asked, how can we set patients up for success? We created a database of over 1,000 mental health resources, searchable by key variables such as zip code, therapy modality, and language, a rough Match.com for mental health. But then we asked, what is preventing success? Over half of our men population has food, housing, and employment insecurity, and nearly 2/3 reported social isolation, yet they are right here in our neighborhood. So we tried 5 pilots. We called, we texted, we monitored, we visited, we escorted. But none of our interventions worked quite as expected. So finally we asked, are patients able to be successful? When motivation and decision-making are compromised by mental distress, people respond in unexpected ways. They may be less risk-averse. They may not respond to outreach or incentives. They may reinforce harmful behaviors. We have so much more to learn about how to engage with our neurodiverse population, but if we get it right, the impact could be extraordinary. So we've accomplished a lot in phase 1. As you can see, our results are quite positive. But the most exciting part is what's left to come. We used our MEND algorithm to map the areas across Penn with the greatest need. Based on these numbers, there's a strong financial case for adding 6 MEND teams to HUP. This could offer a net savings of up to $20 million per year. And we hope to roll this out across Penn Medicine, in our hospitals, in our practices, and in our community. We also hope to pilot new disruptive solutions to our biggest challenge, navigation. Through partnerships and community engagement, we plan to make Penn the epicenter of sustainable and integrated mental health. And if there's one team that's dedicated, energized, and bold enough to make meaningful change, this is it. Thank you to everyone who made this work possible. We are all helping, and the system is a little less broken, so let's continue to mend it together.
So you saw 4 proposals, 4 projects. They were all at the paper airplane stage. It was Healing at Home, Live Aware, Core, and Mend. And let's just have another round of applause for those incredible. I want to give some thanks to lots of people helped with these projects, and of course the Innovation Center more generally supported them, but I do want to call out Matt Vandertine and Deirdre Dara for their special help for this program. So thanks to Matt and Deirdre. And Kevin Mahoney offered to give us some closing remarks, and I will yield the podium to him.
Yesterday we were down at the American Hospital Association. Pat Sullivan was with me and a couple other people in the audience, and we were celebrating Ralph Muller getting the Distinguished Service Award. And it was a great time, and during Ralph's video, if we did a word cloud, innovate and innovation would have come up over and over again. And I think Ralph has showed us the way, and I think we continue to build on that here at Penn Medicine. Ralph was then followed by Senator Blunt from Missouri, who runs the Appropriations Committee, so I was very respectful to him. But he said that a healthy family has many problems. Unhealthy families only have one problem. And I thought about that a lot on the train ride back. I wasn't sure I really liked that statement, but I love Julie D's statement today. We are Penn Medicine. Philadelphia's health problems are our health problems. And I think what you guys showed today is something that only Penn Medicine can do, which is the innovation, the teamwork, the desire, and the earnest application of all your efforts to improve health at Penn, in Philadelphia and across our nation is just really heartwarming to me. To see this today is just incredible, and it shows a lot of effort by a lot of people leveraging our assets, and I encourage you to continue to do that. We spent a fortune on our data, on Epic. I also heard leveraging our other most important asset, which is our people. So the amount of integration. So again, I'll just go back to Julie. I met up in the at Penn Presbyterian, And to see her work spreading so quickly to all the downtown hospitals is just incredible. And love to see all the integration. Tessa was working on HCC, but her last slide was, we can do this for breast cancer, we can do this for lung cancer. That vision, I encourage and applaud you. Don't let the daily budget issues, the daily issues that we have to deal with, cloud your mind and keep that vision in the forefront. The last thing I wanted to point out is that David Ash is in the middle of his budget, and I think all this was staged. So I would give him a little extra. I applaud you. I hope you can join us for a quick reception. I encourage you to keep pushing and pushing and pushing, because that's what Penn Medicine's built for, and I really appreciate all you guys are doing for us. So thank you very much.